Welcome back. In this section of the respiratory anatomy and physiology, we're going to be looking at lung diseases that affect spirometry reading. So just to refresh your memory for a second, we have forced expiratory volumes, forced vital capacities, and FEV1. So the forced vital capacity, that was the volume of air that you can forcibly exhale after a maximum inhalation. And the amount that you can do in the first second is called the FEV1. So we have these two numbers, which are volumes that we can measure, and then we can take a ratio between them. And so what we know is that people with normal lung function can exhale more than 80% of their FVC in the first second. So if we look at the volume for the FEV1 divided by the FVC, that is going to be 0.8 or higher, and that's the normal values. So what happens when we have abnormalities in spirometry? Well, they help us not only assess what's going on, but to distinguish two huge categories: restrictive lung disease from obstructive lung disease. So talking first about obstructive lung disease, what happens in obstructive lung disease is you have an obstruction that literally reduces the airflow. And so when we look at spirometry values for obstructive disorders, we're not only going to have a decrease in the FEV1, we're also going to have a decrease in the ratio as well. In contrast, in restrictive disorders, we are going to have normal ratios, but the lung volume is decreased. So the total lung capacity falls, and we can actually grade these depending on what the total lung capacity is. If you're more than 80% the predicted value, you are considered normal. Okay, but if you're closer to 50 to 60%, then you're considered moderately restricted. So let's look at these two different types of disorders a little bit closer, starting first with obstructive lung disease. So I kind of like this picture because on the right side, it shows you the normal lungs, looking at FEV1, forced vital capacities, total lung capacities, residual volumes, and that's what the four different colors are. And on the left side, it shows you what happens in obstructive lung disease, where you have airway obstruction. And the airway obstruction doesn't prevent air from going into the lungs, but what happens is you have air trapping. And so we have a restriction of exhalation, especially with forced exhalation. If you purse your lips and exhale slowly, you're going to be much more likely to be able to exhale more of your lung capacity if you have an obstructive lung disease. But notice that's not going to be in the first second. And so people with obstructive lung disease have increase in compliance and elasticity. Air gets in, everything expands, but things just don't exhale the way they are. So examples of obstructive lung diseases are people who have chronic bronchitis. Asthma is probably the most prevalent one. And for our smokers or ex-smokers, emphysema and chronic obstructive pulmonary disease. And cystic fibrosis as well, which is totally different, and we're not going to talk about it in this class. If you want to learn more about these, then I suggest you take an upper division pathophysiology or pathology class. Now, in contrast to obstructive lung diseases, we also have restricted lung diseases. And for these, what you'll notice looking at the same type of picture is that the affected lung is smaller than a normal lung. The lung expansion is what is being restricted. So we have a restriction on inhalation, and because we haven't inhaled, then our exhalation values are going to be smaller than normal as well. And we really have lost our elasticity in the lung at this time. So examples of these diseases fall into three big categories. The first are diseases of what's going on, not in the air spaces themselves, but in the interstitial spaces. And those are inflammatory diseases such as pneumonia, whether viral or bacteria. Now, sometimes the sequela of those interstitial diseases will lead to long-term fibrosis. We're finding that out in COVID patients. But in addition to that, you can get pulmonary fibrosis from having jobs where you have to inhale particulate matter, whether it's asbestos from doing paving and roofing, or silica, or certain medications, or if you're a firefighter, not wearing your mask and getting all that ash down in your lungs. And the third big category for restrictive lung diseases have to do with problems really of the chest cave, not really the lungs. The first is a pneumothorax, which yes, does involve the lung because the lung collapses, but it's usually due to a problem with the chest and injury to the chest itself. The point being you have air surrounding the lung, which causes the lung to collapse. You also, if you've ever had a rib fracture, you know you don't want to take deep breaths because it hurts with every single breath. And so you are purposely restricting your inhalations and exhalations to avoid pain. People who have scoliosis or kyphoscoliosis, kyphosis being the dowager's hump leaning forward and scoliosis being the sideways curvature, would also, just because of the shape of their chest cavity, have marked restrictive lung disease. And myasthenia, which is a neurological disorder that affects muscle contractions. If you have a problem with your muscles contracting for breathing, that automatically gives you a restrictive lung disease. So with that, we are completely done with our respiratory sections, and I hope you have enjoyed this part, and I look forward to seeing you again in our next class. Thank you for all your work.